the speaker.
Okay. Okay. Yeah, okay. That's good. All right. Welcome, everyone. Double check a few things. Welcome, everyone. This is the VCU Department of Internal Medicine Grand Rounds. Today is Thursday, October 24th, 2024. Just as a reminder, Grand Rounds is here downtown on the MCV campus and virtual. We are in the Molecular Medicine Research Building. And to get your CE credits, you're going to need to text this code or scan the QR code for the residents and the interns. So the Department of Internal Medicine, each division, we have 11 divisions, gets to have two sessions each year. And so today's session is brought to us by the VCU Division of Pulmonary Disease and Critical Care Medicine. To introduce our speaker, I'm going to bring up Dr. Daniel Grinnan. Dr. Grinnan is Professor of Medicine in the Division of Pulmonary and Critical Care Medicine, Director of our Pulmonary Hypertension Center, and now the Associate Division Chief for Clinical Affairs. Come on up. Yes, thank you.
Thank you. What an honor to introduce Dr. Barry Fowler for Grand Rounds today. Dr. Fowler first came to VCU, MCV, in 1975, went away for fellowship at University of Colorado, which is really well known for developing chiefs of divisions, departments, curious researchers and successful researchers, and came back on faculty here in 1982. And we've been very fortunate to have him here ever since. He was chair of the Division of Pulmonary and Critical Care from 1998 to 2015. While he's been here and a leader of our division, he's really helped to foster a culture where we, being our pulmonary and critical care faculty, are very much encouraged to be curious, to be asking questions, to be looking at things through a different lens. So much so that when he would round in the MRICU, rounds would often extend past noon because everyone was having fun asking questions, trying to learn, but also a culture that really prided teaching and mentoring. I think probably every member of our division has had a big impact from Dr. Fowler on their career. And he's been a very successful researcher, too many accomplishments in that realm to go through. So it's very appropriate that when we look at the topic for today, the history of our division, there's no one better to give this talk than Dr. Fowler. This is a chance. I think we're also busy looking forward. It's hard to take a minute and to look back, but if we don't look back, then we forget where we've been, and that's how we know what to do when we're going forward. So I'm very much looking forward to this, and we'll turn it over to Dr. Fowler. Thank you.
Good afternoon. I want to thank you very much for asking me to do this. It's been a lot of fun putting this presentation together. As Dan just mentioned, the pulmonary division is a lot about mentoring. And I see this audience here, many of the doctors that walk around this medical center were formerly my residents in the intensive care unit on the consult service in the endoscopy suite. And I think I'm going to convince you that the history of our division very much is a history of mentoring and has a lot to do with the development of pulmonary medicine over a 97-year period. All right. So tell me what I'm doing. Got it. Okay. Thank you. So as I mentioned, we have approximately a 97-year history, but it began in a way that you would never believe. And it started, as far as I can probe back, with a physician that probably everybody in this room knows from the history of our medical center, with William Branch Porter. Dr. Porter graduated from this medical school in 1911 and did 1 year of, they didn't exactly call it internship, but he did 1 year of training and went into the practice of general medicine in 1912. And practiced in Richmond for about 5 years. And then there was the outbreak of World War I. And one of the two amazing accomplishments of this medical university was the creation of the 45th General Hospital. And Dr. Porter volunteered, along with a number of other physicians and surgeons, to go to Paris, France, to begin his work for approximately a year and a half in the 45th General Hospital, where, as you can see, tuberculosis, it was estimated that 10 or 15% of the GIs that went to World War I were tuberculosis positive. But mustard gas, lung injury, malaria, and it was right in the middle of the pandemic. And this is the influenza pandemic. The 45th General Hospital, from approximately spring of 2018 until the summer of 2019, took care of 33,000 soldiers. And after the war was over, 2018, Dr. Porter decided not to return to Richmond, but instead he took an opportunity for real internal medicine training by two of the great early physicians, Sir William Osler, who was at Oxford, and Sir Thomas Lewis, both of whom were in London. And he stayed there training with them for approximately 2 years and became really interested in pulmonary and cardiac medicine, both of whom were in their infancy at that time. Following 2 years there, he returned to Virginia and became head of medicine at the Lewis Gale Clinic. Within a very short period of time, possibly 4 or 5 years, all of a sudden the Lewis Gale Clinic became a place where if you had disease, you had to be. And he gained a very dramatic reputation as a physician. And it was at that time that Dr. William Sanger, who was the first president of MCV, went to the Lewis Gale Clinic in Roanoke and convinced Dr. Porter to come to MCV at that time. And in 1927, he was made as the first permanent chairman of medicine at VCU, then MCV. Upon his arrival, he continued to feel the importance of lung medicine, as they called it back then, and was really in favor of the development of the new imaging technique called chest x-rays. And he became also very adept at diagnosing various diseases of the chest. And the importance of West Hospital, its construction, was the heavy involvement of Dr. Porter working with the architects and other individual administrators here in the construction and opening of West Hospital in 1941. But then everybody in this room knows what happened in 1937. World War II broke out. And very similar story, a young physician who was mentored by Dr. Porter, William Taliaferro Thompson, volunteered for the 45th MCV 45th General Hospital and served in Naples, Italy for 2 years during World War II. And it was very interesting, just as a sidelight. My mother was a Red Cross nurse working in this hospital and worked with Dr. Thompson. during World War II. And so tuberculosis was prevalent both in our troops as well as the prisoners of war, pneumonia, malaria also. And from spring of 2018 until summer of 2019, the 45th General Hospital took care of over 40,000 individuals, which also included prisoners of war. I read the genesis of that MCV General Hospital, and approximately 5,000 individuals, over 700 physicians and surgeons, close to 1,000 nurses, and various medical personnel and laboratory technicians went to Italy as part of the 45th General Hospital. Dr. Thompson went through the ranks from lieutenant to major and left the Army after the close of World War II and returned to Richmond and was assigned to the McGuire Clinic, which has subsequently become the McGuire VA Hospital, which has subsequently become the Veterans Administration Hospital. And his interest in pulmonary medicine never died. It was started by Dr. Porter, and it continued because of his experience with the 45th General Hospital and the World War II era McGuire Clinic. He became chairman of the medical service there and set up the VA pulmonary ward, which was virtually in the beginning all dedicated to tuberculosis care. Dr. Thompson hired 4 physicians that specialized in tuberculosis care of the 1950s and also worked very much with the design of North Hospital with Dr. Porter. And when North Hospital opened in 1955, the top 2 floors were opened as a tuberculosis sanatorium. And so pulmonary medicine sort of continued to flow on. And one of the initial tuberculosis doctors was Dr. Orrin Murin. And I'm sure there are people in the audience who remember Dr. Murin. It was in North Hospital where triple therapy for active tuberculosis was actively researched during this era. Dr. Thompson left the VA hospital and was appointed chairman of medicine here at MCV in 1959. And continuing his interest in pulmonary medicine, established the pulmonary division in formal pulmonary division in 1960. And he recruited Dr. Edward Ray, who specialized in the early care of sarcoidosis, and recruited a significant researcher who was a pulmonary physician, Sami Saeed, who I'll mention later, as well as Dr. Murin. And within 1 year of that time, the pulmonary fellowship was established with 1 pulmonary fellow trainee per year. The Pulmonary Function Laboratory opened in 1961. We first began to analyze arterial blood gases in 1965. All of this was under the push of Dr. Thompson. When Dr. Thompson took over as chairman of medicine, there were 11 full-time faculty. By the time he retired in 1973, there were 79 full-time faculty. And so he had a major influence on the practice of internal medicine here. The sort of launch of critical care medicine for the pulmonary division occurred when the NIH announced competition for dollars to be able to create an area of intensive care in a hospital dedicated towards respiratory medicine and respiratory failure. And MCV, Dr. Thompson, Dr. Patterson, who was a pulmonary physiologist, applied to the National Institutes of Health and won 1 of 5 awards for the creation of the respiratory ICU on the 5th floor, south wing of West Hospital. And it was primarily a respiratory failure unit, not so much a critical care unit. It was during that time that James Baker created the respiratory care department here. Also, Dr. Mirren went for 3 months to the University of Iowa to work with Donald Zavala, who was creating this technique called fiber optic bronchoscopy, and returned to VCU MCV at that time and performed the first fiber optic bronchoscopy here in 1972. When Dr. Glauser was created in 1976 from the University of California, he made it very clear that the medical ICU should only be attended by people with pulmonary and critical care training. And so he created the concept of a closed ICU. The respiratory ICU in 1982 combined with the general medical ICU to create the medical respiratory ICU. It was at that 1983 that the World War II era McGuire Hospital, VA hospital, was torn down, and the new VA hospital, as it is now, was constructed and opened in 1983. Main Hospital was constructed in 1983. The MRICU moved to a 16-bed unit. Subsequently, the Critical Care Hospital was constructed in 2008 as a 28-bed unit. And for the pulmonary attendings in this room, you would probably laugh thinking only 28 beds, because it frequently will get up to 30 or 35 patients during the cold and flu season. Important to the evolution of the pulmonary division was the establishment by the Department of Radiology with specialists who were trained just in thoracic imaging. And in 1982, for us that were attending at that time in the medical respiratory ICU, we would end our rounds every day in the Department of Radiology, rounding with the thoracic imaging. I see you nailing your head because you remember those days. As thoracic imaging developed, by the time 1990 rolled around, I was getting coffee one day with one of the thoracic radiologists, and he looks at me and says, "We see some of the most interesting cases in the hospital. Why are we not having a conference?" And thus the Friday conference was formed in 1990, and it goes year-round every Friday. And the way it's designed now is one conference per month is an interstitial lung disease conference where multidisciplinary decisions are made about patients with pulmonary fibrosis. And the other 3 Fridays of the month are presented by pulmonary critical care fellows. And it's primarily dedicated for training in thoracic imaging. The Pulmonary Fellowship has been going on now for 63 years. I mentioned Dr. Baker originally directing the respiratory care department, and there have been a succession of pulmonary fellowship directors. Currently, one of the most amazing doctors in this institution, Dr. Brath, is respiratory care director, the pulmonary fellowship director, as well as the unique pathogens unit, as everybody is aware. Pulmonary hypertension originated here in 2000 with Paul Fairman initiating it. In 2006, Dan Grennan arrived from University of Virginia and became a member along with Janet Pence and Laura Savage and the others, Liz Sontag and Ms. Lester. Wes Shepard trained here in internal medicine, and following pulmonary critical care training here, he went to the Leahy Clinic where he trained for a year and returned here in 2004 fully trained in interventional pulmonology. A year later, the Interventional Pulmonology Fellowship was created, and we've had a number of different attendings. Hans Lee and Samira Soji in the past, Denai Kameshuan and Dr. Uchel are currently attendings, and that service usually performs over 1,000 procedures annually. The medical respiratory ICU, the beloved MERCU, really had its concept established in 1976 when Fred Glauser arrived. And we've had a succession of directors. Most recently, Kurt Sessler was the director of the MERCU for a number of years. And now Kristen Miller has become the full-time director of the MERCU. And the pulmonary critical care faculty, as you know, it's a closed unit, and the pulmonary critical care faculty attend in that unit every day of the year. We have been teaching M2 respiratory medicine since 1985. The curriculum was started by Paul Fairman. In 2002 or 3, Mary Lan DeWitt took over and did it for a number of years, and Sammy Pedram now is the director of M2 respiratory medicine and is modeling the service for the students according to some modern concerns about medicine and point of care imaging. Kristen Miller, besides being at least an interim director of the MERCU during the last several years, since she joined the faculty here, has been providing pulmonary care for patients who have had bone marrow transplant, stem cell transplant, CAR-T infusion. And this is due to the frequent occurrence of pulmonary abnormalities that occur, especially with bronchiolitis obliterans in the 4 to 5 years after transplantation. The human simulation laboratory has evolved over time and is now a very large operation. Kathy Grossman was the interim director in 2016, and she became the full-time director at the onset of the pandemic in 2020. Critical care ultrasound was originally established here by Sammy Pedram. He was initially interested in training pulmonary fellows, but critical care ultrasound has expanded to teaching of internal medicine residents and recently M2 medical students. Pulmonary attendings at various points have attended in the cardiothoracic ICU. Most recently, Dr. Patel, who has joined our faculty recently. The Adult Cystic Fibrosis Center was established in 2014 with the recruitment of Dr. Nauman Chowdhury. He currently cares for about 130 adult CF patients, with the average CF patient being in the hospital 2 to 3 times per year with respiratory abnormalities. It's a busy service. The Multidisciplinary Sarcoidosis Center was established by Amr Syed, Tom Iden, Hussefa Syed, and Jordana Crone for the care of patients with sarcoidosis, and they currently care for approximately 2,000 patients from all around the state of Virginia and surrounding states. Rapid response became the responsibility of the Pulmonary Critical Care Division in 2015. Some of you may remember Marcos Cassioris, who left us a couple of years ago. Now Casey Cable directs that service with a host of nurses that are experienced in critical care and identifying acute changes in a patient's hospital course. With the arrival of Dr. Syme in 2019, we shifted a major focus to the care of patients with interstitial lung disease. And it was shortly thereafter that Apostolos Paralis established a monthly interstitial lung disease multidisciplinary conference that is focused on patients who are suffering from pulmonary fibrosis and making decisions concerning the care going forward of those patients. James O'Connor arrived in 2019 with specific training in pulmonary rehabilitation and is currently the director of pulmonary rehabilitation for this institution. Kathy Grossman, initially in the early 2000s, managed a difficult asthma clinic that over the years has evolved. We take care of a lot of patients with asthma. And in 2021, Farouk Abbas arrived and is leading the charge against severe asthma. And recently, Stephanie Bork has joined him in the care. And then in March of this year, we were fortunate enough to get this doctor right here, Vipul Patel, to head up medical direction of the Lung Transplant Center, which has been activated. The VA hospital currently has 5 attending physicians. Research in the pulmonary division really began back in the 20s and 30s when Dr. Porter, who was very interested in research and training of internal medicine, Dr. Thompson continued this mentoring. As I said, increased the Department of Medicine numbers faculty-wise by a large amount. But Sami Saeed had an interest in vasoactive intestinal polypeptide and published many articles and had years of NIH support of this molecule, which regulates circulation into the mesenteric area in humans. He used a number of animal models to study VIP. When the respiratory ICU opened, it was Dr. O'Donoghue, Walter O'Donoghue, and James Baker who began actually studying the evolution of early mechanical ventilators, which were used in the 60s. That was when the respiratory ICU opened. Many publications arose out of that in the 9 years or 8 or 9 years after the opening of the respiratory ICU. Lung injury research began to occur in large amount with the recruitment of Dr. Glauser. Dr. Paul Fairman participated in that work, as well as Kurt Sessler and Dan Bichard. All of these physicians have either retired or passed away. Many of you all know of the work that has been done by my laboratory for many years. Our interest was on sepsis, acute respiratory distress syndrome, and lung injury. And my colleagues, Bernard Fisher, as well as Ramesh Natarajan, were with me for about 38 years. Shobha Ghosh, who was a very talented researcher, passed away in 2021, but her total focus was on lipid homeostasis. Maryland DeWitt had a dedicated research effort for weaning from mechanical ventilation in patients with acute respiratory failure and developing protocols for weaning patients from mechanical ventilation. Wes Shepard and his colleagues through the years have focused a lot on the interventional pulmonology technology. A lot of work is being done now with insertion of valves in patients who have a significant degree of air trapping, and the valves help to deflate the lung of patients with substantial emphysema. Before she left, Samara Soji was totally focused on malignant pleural effusions, and she has since moved to Vanderbilt. Pulmonary hypertension is now the work of Dr. Dan Grennan, Janet Benson, and colleagues, and I think it's really important that it's ongoing. Sarcoidosis research is multidisciplinary. There is a large focus on cardiac inflammation in patients with sarcoidosis. When Dr. Nanasinkum arrived in 2016, he was very focused on obtaining microparticles from the circulation to sequence the RNA and microparticles as a means of trying to predict the kind of lung cancer that might be present. Samara Soji joined him during this time. Dr. Acunzo and colleagues continue that work today. Interstitial lung disease is high on our list currently. Patricia Syme is a world-known researcher, has just arrived back from Greece. And that research is going on. Maggie Freebergen, the white sweater back here, has an amazing research going on and has just been NIH funded. The McGuire Hospital has focused on lung cancer with the Lung Precision Oncology Program, the Fowler, which is surgery or radiation of the chest, as well as lung cancer biomarkers. So I'll wrap up here and just say, this was the pulmonary division downtown in 1997. These were the faculty members of the pulmonary division in 1997 at the VA. This is the pulmonary division today. So I think our history continues. And I think if I can make a leap of thinking about our history, it really began with Dr. Porter and his experience during World War I, and then his experience being a student of Dr. William Osler. Probably many people in the room know about Dr. Osler, and Dr. Porter was there when William Osler developed pneumonia, empyema, and sepsis and died during his time training with Dr. Porter and Dr. Lewis Thomas. So let me stop there and open up for questions.
Thank you. We'll start here in the audience. Any questions, comments?
Not a lot of history buffs, huh?
Yeah, thank you, Barry. That was just amazing. I learned some things I didn't know. And I think one of the things that is sort of incredible is the legacy of some of the named professorships. So you hold a professorship, I hold a professorship, and it's that ability of professorships to invest in the future. So I have a question for you. What do you think are the major challenges for the field of pulmonary and critical care in the years ahead? Can you forecast the next 10 and 20 years of things we really need to tackle as a broad pulmonary and critical care community?
Well, as far as critical care medicine, you know, my almost career-long focus was on acute lung injury and sepsis. And we had some good results with the vitamin C trial. But I think conquering sepsis for critical care medicine, conquering acute respiratory distress syndrome. If you look at the yearly budget of an intensive care unit, 33% of all insurance charges occur as a result of acute respiratory failure. And there's been a lot of work. We just finished up a major trial with no real positive results. I think what we're going to see, especially knowing how the field of interventional pulmonology is rapidly advancing. Wes and I talk frequently, and he tells me new techniques, which includes robotic bronchoscopy, where very tiny nodules can be biopsied from bronchoscopy as opposed to transthoracic needle aspiration. More effective antibiotics. I know, looking at Gonzalo back there, they're always having to juggle complex antibiotics because resistance is evolving so rapidly. I don't really know where. I think one of the important things that after just coming back from a trip in Europe, things are very inexpensive there. Things here are very expensive, and insurance is controlling the practice of medicine. Insurance companies is controlling the practice of medicine. I see a lot of head nodding, which it is absolutely true.
Thank you, Dr. Fowler. I love the history of the Pulmonary Critical Care Division. I always love hearing from you and from people like Richard Wenzel on the history of VCU and MCV. So my question is, it's really clear from your presentation that Pulm Crit Care and many other divisions here have always had a very academic nature. There was a lot of research, and that was really integral to the entire mission of the divisions. So how do we maintain that and continue to foster that academic nature in a day and age when all anyone seems to care about is productivity and RVU, and that seems to be mentioned every other day, at least in my experience. So I welcome your thoughts on that. How do we keep engaged? How do we keep young physicians curious, make them, continue to encourage them to be academic, to publish papers and see the value in that?
I appreciate that a lot. Riding alongside of research is the increasing complexity of clinical medicine. And one of the important features of a life in research is to be able to translate what happens in the laboratory to the bedside. And a lot of what we have done over the years has been focused on that. A lot of research that's currently going on within the Department of Medicine is translating to the bedside. The trick is, in a busy clinical department, is recruitment of talented young people who are focused on the bench, who have knowledge of clinical medicine and can translate through multidisciplinary research from the laboratory to the bedside. I don't know. We have a very important chairman of medicine here with us who has done that quite successfully since she arrived. Do you have some input, Dr. Simon?
Yeah, no, it's a great question. I think it's a struggle for everybody, not just here, but actually across the world, is how do you maintain the academic mission? I would tell you, we've topped $100 million now in the department recently of extramural funding, which is unbelievable. So, and that's been a steady increase every year. And I think you're right. I think we have to identify people with interest and talent in the research space. And it is one of my jobs to try and get the funding to protect people's time, because you do need time to be trained and to be successful in competing for funding. But, I'm very proud of the department, actually. I think we've, despite all the pressures, the productivity pressures that I think we're all under to some degree. And what I really enjoy is we're starting to see our colleagues come into the research space. So we have EPPs now joining us doing some research, and we have, fantastic teams. And I think in our world where team science is really how to get things done, we're incredibly well placed here at VCU in many ways because we're so collegial, right? We get together, we know each other, we like each other, and we can share our passion for discovery and just doing better for every patient that crosses our door. And, sometimes it's good just to wander the floors in the hospital and you just see amazing, quiet things going on. And it's direct care for patients, but it's the questions for tomorrow. And so, I think it's a battle we have to continue to fight. But I think we're doing well, and there's lots of great people, mentoring you mentioned, you are a fabulous mentor. And we have a history, I think, in Pulmonary, but also in other parts of the department of fantastic mentoring relationships, which are really bi-directional and so important to the mentee. But honestly, they're really important to the mentor too. So, I think you've done great things in pulmonary critical care, and we see great things bringing in people to the department at large. So, it's a challenge for us all, but one I'm excited to continue to grapple. And we will soon have our state of the department. And I promise I have one slide that maybe mentions RVU, and everything else is the research and the education. So, and I think for those that are available tomorrow, the dean is doing the town hall with us tomorrow at noon. So I think you'll hear a little bit from him on the research missions and the education missions, and which really are, I think, integral to patient care. It's the patient care for tomorrow.
But a very important question, Gonzalo. It's what every medical school should be doing.
Any other questions here? Let me just check online to see if we have any folks online. Any questions? Let's see, we got. Just some thanks and acknowledgements. Any other questions from the audience here? All right, well, please help me say thank you to Dr. Fowler. Appreciate it.